Hello everyone, welcome back to my channel. If anyone new over here, I am Dr. Dhanya. This channel is mainly focusing on AMC exam preparations, and we have started with maternal health for your preparation, and so far we have covered the topics initial assessment for early pregnancy bleeding and miscarriage management. Today we will discuss about the topic ectopic management. So let's get started. So before moving into management part, let's have a quick brush up on your basics. What is ectopic? It is the implantation of conceptus outside the endometrial cavity. It occurs in 1 to 2% of cases. In Australia, it is responsible for 80% of maternal death in the first trimester. When a case of ectopic is there, we should refer the patient to the tertiary care center. What are the sites of implantation? Fallopian tubes are the most common site, in which ampulla is the most common one. And the other sites are cervix, C-section scar, interstitial or cornual, ovaries, and it can occur anywhere in the abdominal cavity and also in concurrently with the intrauterine pregnancy. In that case, it is known as heterotopic. So what are the risk factors? Previous history of ectopic, previous pelvic surgeries like C-section, tubal surgery, appendectomy. Smoking. Smoking is very important in Australia because here a significant number of women will smoke. And previous pelvic infection or pelvic inflammatory diseases. These two, smoking and pelvic inflammatory diseases, these two are important in Australia, especially the chlamydial infection. So these two are affecting the ciliary motility and that will affect the transport of embryo into the uterine cavity. And intrauterine contraceptive device or failure of contraception, and history of fertility problems and assisted reproductive techniques, progesterone only contraception, age more than 40. All these are the risk factors. So when it comes to clinical presentation, symptoms and signs, there is a triad with history of secondary amenorrhea and pelvic pain or localized abdominal pain or unilateral abdominal pain and irregular spotting or bleeding per vagina. In some cases, there is palpable adnexal mass also and adnexal or cervical motion tenderness also. When there is ruptured ectopic, there is shoulder tip pain or diaphragmatic pain and dizziness or spells of fainting and hemodynamic compromise or signs of peritonism. What do you mean by peritonism? Inflammation of the peritoneum. So all these indicate the rupture ectopic. So for confirming the diagnosis, we need investigations also. Here the serum beta hCG will be positive and on ultrasound there will be empty uterus with or without pseudosac. What do you mean by pseudosac? A fluid collection inside the uterine cavity due to residual reactions. In most of the cases there is adnexal mass which is looking like a heterogeneous mass associated with a free fluid in most of the cases, which is also known as blob sign. In some cases, we can see a gestational sac there with or without a yolk sac, and in rare cases, we can see live fetus also. Please note that an adnexal mass will not be found in small minority of cases, and when clinical or USG findings are not conclusive, we should move with diagnostic laparoscopy for further evaluation. This is an ultrasound image with Doppler showing a live ectopic. You can see a cardiac activity here in the Doppler. This is the ectopic, and you can see the empty uterus. This is the blob sign or donut sign. You can see a heterogeneous tubal mass here like a donut. This is also a donut sign showing a tubal ectopic. You can see a gestational sac with yolk sac there. This is also an image of tubal ectopic. This is the uterus. Tubal mass is here And this is the left ovary here. You can see the corpus luteum in the ovary. This is an image of ruptured ectopic. We can see the heterogeneous collections are there surrounding the uterus. This is a laparoscopic image showing tubal ectopic. This is a posterior surface of the uterus. You can see this is a fallopian tube, left fallopian tube. This is the tubal mass. What is this structure? This structure. Round ligament. This is the fallopian tube. What is this structure? This ovarian ligament. This is the right ovary here. Then what is this? You can see an empty uterus here. There is no gestational sac inside the uterine cavity, but there is a pregnancy at the region of cervix. This is a cervix. So you can see the gestational sac at the level of cervix. So it is a cervical pregnancy. This is also an image of cervical pregnancy. You can see empty uterus here with cervical pregnancy. Then what is this? This is the uterus. This is the endometrium. This is a posterior wall, anterior wall. So what is this? A scar pregnancy. Cesarean scars pregnancy. This is also an image showing cesarean scars pregnancy. This is the uterus, endometrium, anterior wall. So this is the scar area of uterus, and from there a gestation is developing. From this image you can differentiate between the pseudosac and the true gestational sac. The first image showing the pseudosac and the second image showing the true gestational sac. Pseudosac can vary in shape during the examination itself, but the true gestational sac is round in shape, and pseudosac is more towards the center of the endometrial cavity, but true sac is more towards the eccentric part of the endometrial cavity. And true sac, there is two heterogeneous rings. In pseudosac only one outer layer, and when examined with the Doppler we can see peripheral vascular flow in the true gestational sac, but the pseudosac will be avascular. Now we can move on to the management part. In this session, I will mainly focusing on guidelines for management of tubal ectopic. I won't be covering non-tubal ectopic management in detail, but I will cover some important points from that also. So let's start with the tubal ectopic management. Here also we have three options like surgical, medical and expectant management. First, about the surgical management. What are the indications? When patient is hemodynamically unstable or when there is intraperitoneal bleeding, we should prefer surgical management. If patient prefer surgery or if she is also seeking sterilization, and if beta HCG is more than 5000 international unit, or if there is a live fetus, or if adnexal mass is more than or equal to 35 millimeter size, or if a subsequent pregnancy affected ipsilateral tube after previous medical or expectant management, we should prefer surgical management even if the patient is stable. So the gynecology registrar will explain the treatment to the woman and the partner and provide information booklet on ectopic and obtain a written informed consent in which explain about the injury to the surrounding organs such as bladder and bowel, and explain about the risk of catastrophic bleeding and death from the vascular injury, and arrange date and time for surgical management including the booking of operation theatre and inpatient bed, and arrange or request for pre-treatment investigations and prescribe anti-D for Rh negative women according to the guidelines. We can do procedures like salpingectomy or conservative procedures like salpingostomy or salpingotomy. In salpingectomy, the affected tube is completely removed either by laparoscopic approach or open approach. And in conservative like salpingostomy, we put a linear incision over the antimesenteric border and remove the products. Then we left the tube there and allow it to heal on its own. In salpingotomy, similar to salpingostomy, we started the procedure, but after removing the products, we close the incision. The left image is of salpingectomy, and here we remove the tube completely. The right side one is salpingostomy. Here we put a linear incision over the antimesenteric border of the fallopian tube and remove the products and left it as open. So usually we do salpingectomy for the management of ectopic, either laparoscopic or open salpingectomy. It is mandatory when there is significant intra-abdominal bleeding and when there is hemodynamic instability or there is free fluid above the level of uterus and or in Morrison's pouch. A laparotomy may be performed when there is lack of equipment or expertise and if the woman is in extremis. If the patient is stable, laparoscopic procedure is preferable than open procedure. This is an ultrasound image showing collections in the Morrison's pouch. You can see the liver here, right lobe of liver, right kidney here. This is the Morrison pouch in which there is a collection. This is also the image showing collections in the Morrison's pouch. This is the liver, right lobe of liver, right kidney here, between this Morrison's pouch. So if the patient is hemodynamically not stable, we should resuscitate the patient first and secure immediate IV access and start with fluid management. And at the same time, we should send sample for the complete blood count and cross matching. Arrange 4 units of blood minimum and inform operation theatre and anesthetist and on-call gynecology consultant. In most of the cases, we need an emergency surgical management even before fully replacing the blood and fluid losses. If the tube is severely damaged and if there is uncontrolled bleeding, if there is recurrent ectopic pregnancy in the same tube, and if there is a large tubal pregnancy of more than 5 cm, and if the patient has completed her family, we should always prefer salpingectomy. If the tube appears morphologically normal at the time of surgery, seek a second opinion with another gynecologist or on-call ultrasound consultant prior to salpingectomy. And the content should be sent for histopathological examination and should give anti-D immunoprophylaxis if needed. A recent multi-center international trial comparing laparoscopic salpingectomy with laparoscopic salpingostomy showing no difference in subsequent fertility outcomes. However, persistent trophoblastic tissue requiring further treatment was more common in salpingostomy group. The majority of women therefore have salpingectomy. But in cases where the contralateral tubal damage is there or when there is absence of contralateral tube, we should prefer salpingotomy for such patients. On discharge, the gynecology registrar will provide contact numbers or appointments for Women's Social Support Service and information booklet on ectopic pregnancy and advise women to see a GP on next week for removal of sutures and what to expect in terms of pain, bleeding, etc. To take simple analgesia for pain and to contact registrar of unit that operated on the patient or women emergency center if concerns regarding pain or bleeding are there. Also ensure contraceptive plan is in place and ensure clinical review is planned to discuss the relevant issues regarding the future fertility and pregnancy. And the registrar should complete the discharge summary and ensure that a woman's GP is informed. Now about follow-up and monitoring in special circumstances. If patient underwent salpingotomy or if any doubt remains about the diagnosis or completeness of the removal, notify the emergency pregnancy assessment service or follow-up plan and which unit is responsible for the patient, and we require day 3 and day 7 beta HCG in that case. And if any abnormal symptoms or any abnormal results, review by the gynecology registrar. If beta HCG plateaus or rises, consider the medical treatment, and repeat ultrasound examination should be done after 1 week of postoperative period, and it must be discussed with the ultrasound consultant. Now about medical management of ectopic. Here we use systemic or intramuscular methotrexate. It is used when the patient is stable and if there is less chance of hemorrhage or rupture as an alternative to surgical management. But the woman should clearly understand the risk and indicators for seeking urgent care, and she should be willing to attend regular follow-up. So what are the criteria for considering a medical management? The patient should be hemodynamically stable and there should not be any pain or if mild pain, and if there is no significant pelvic tenderness on vaginal examination, and the serum beta HCG should be less than 5000 international unit. Please note that even in lower level of beta HCG there is risk for bleeding or rupture. And on ultrasound, if there is no fetal cardiac activity, we can consider. If there is unruptured ectopic or if a mass of less than 3.5 centimeter with no significant blood in the peritoneal cavity, or if there is no significant blood in the POD, we can consider medical management. And if the patient will use reliable contraceptive for 3 months from the last methotrexate use, we can use. And if there is no liver, renal or bone marrow impairment, we can use methotrexate. Also, if there is no coexisting intrauterine pregnancy, we can use. And if there is no contraindications like aplastic anemia or active liver disease, we can use. And if patient is not currently on NSAIDs and diuretics, penicillin and tetracycline group of drugs, we can use methotrexate. Actually, the drug interactions are mainly affecting in multi-dose regimen. This is not important for single-dose methotrexate regimen. So what are the side effects of methotrexate? There is a reduction in liver function for a short period of time, and colic, abdominal pain, nausea, vomiting, diarrhea, increased sensitivity to the sunlight. But these side effects are generally minimal in single dose regimen. So what are the contraindication to the medical management? If there is hemodynamic instability or free fluid or blood in the Morrison's pouch, all these indicating the rupture ectopic, and if there is no access to 24-hour telephone advice or patient is unable to comply the treatment plan, and if there is any presence of intrauterine pregnancy or in cases of heterotopic pregnancy, and if there is immunodeficiency, if sensitivity to methotrexate, and if pre-existing liver disease, hematological abnormalities, pulmonary disease, peptic ulcer disease. So these are the baseline blood tests that we should do before starting a medical management. There should be a quantitative serum beta HCG, full blood examination, liver function test, serum urea, electrolytes and creatinine, and blood group RH typing. If patient is RH negative, antibody status also. So for tubal ectopic management, we usually start with a single dose regimen. And here we use the formula 50 milligram of methotrexate per meter square of body surface area for calculating the total dose. And the total dose is given as intramuscular dosage. And the maximum dose is capped at 100 milligram. And the recommended formula for determining the body surface area is by Mosteller method. That is square root of height in centimeter into weight in kilogram divided by 3600. Suppose if the patient's height is 165 centimeter and weight is 65 kg, then body surface area from this is square root of 165 into 65 divided by 3600. This will finally become square root of 2.979, that is equal to 1.726. So after getting the body surface area, we calculate the total dose as 50 into 1.726, that is equal to 86 milligram. So after calculating the total dose, we have to round this calculated dose to the nearest 10 milligram. So that will round to in 90 milligram. This is to help for easy administration, and in Australia there is the pre-filled syringes available starting from 50 milligram and 70, 80, 90 and 100. So it will help in easy administration also. So obtain a written informed consent from the patient before administering the drug, and arrange admission onto the ward, especially the chemotherapy ward, for administration of methotrexate. And women should be provided with a written information about what to expect and suggested behavioral modifications needed, and follow-up appointments. And the cytotoxic handling precautions should be followed, and the methotrexate should be administered by the appropriate trained staff. Anti-immunoprophylaxis should be administered to the Rh negative woman on the day of diagnosis or day 1 of the treatment. So what are the additional consideration in case of methotrexate treatment? The woman should cease their folic acid containing supplements. Why? Methotrexate is folic acid antagonist. It inhibits the folic acid metabolism by inhibiting dihydrofolate reductase enzyme. So we should ask them to stop folic acid containing supplements during the treatment, and also avoid ultraviolet light exposure, and avoid alcohol intake for about 1 week duration, and avoid ingestion of high FODMAP food to minimize photosensitivity and abdominal discomfort. What is FODMAP? Food containing fermentable oligosaccharide, disaccharide, monosaccharide and polyols. There is chance of separation pain after 3 to 6 days of treatment. So we should ask the patient to take paracetamol, or if the patient's creatinine is normal, she can also take NSAIDs for pain relief. If there is heavy pain, or if she require stronger analgesia, or if there is any symptoms of hemodynamic instability, medical review is indicated to rule out rupture. Also, the subsequent pregnancy should be avoided for 3 months after the treatment to minimize the congenital anomalies. Also, ask the patient to avoid sexual intercourse for a period of 2 weeks. Contraception should be provided to the patient, and if the patient is breastfeeding, advise the patient to express and discard their breast milk for 4 days after a single dose of methotrexate. Usually, the methotrexate will not have any long-term side effects, or it will not cause any future pregnancy losses or future congenital anomalies. But in patient with ectopic, there is a chance of or increased risk for another ectopic in her future pregnancies. So we should advise them regarding that. So how will you monitor or follow up a patient after methotrexate administration? The day of first dose is taken as day 1, and we need a clinical review by the gynecology registrar on day 4. with the beta SAG report. And on day 7 also the clinical review by the gynecology registrar with the full blood count, a beta SAG, LFT and RFT. If the serum beta SAG fall more than or equal to 15%, then we need to review the patient every weekly until the beta SAG become negative or the beta SAG become less than 5 international unit per liter. And it may take several weeks to fall, but we ask the patient to check beta SAG every week. And on day 14 onwards, we need a review in emergency pregnancy assessment service, and there the patient should also check the full blood count also, and if any clinical indications or if there is any abnormal symptoms or abnormal blood reports, we should refer the patient from EPAS clinic to the gynecology registrar. Suppose if there is suboptimal response to the methotrexate, that is a beta SAG rise or a fall of less than 15% between day 4 and day 7, we should reassess the patient for suitability for ongoing medical treatment based on the clinical assessment and serum beta SAG level and or ultrasound examination. And we should consider the second dose of methotrexate in that cases on day 7 if patient is suitable for the treatment, and this is required in nearly 15% of cases in the medical management. If there is any evidence of rupture, we should discuss with the consultant gynecologist for the surgical treatment. So the second dose is given on day 7, and we should confirm a normal LFT report before administration. The injection should be given in the opposite gluteal region from the first injection, and we need a review on day 11 with beta SAG to the gynecology registrar, and on day 14 with a full blood count, beta SAG, LFT, RFT to the gynecology registrar. And if there is any evidence of rupture or any significant pelvic pain or any abnormal clinical findings, we should discuss the case with the consultant gynecologist for surgical management. Similar to surgical treatment, here also after completion we should ensure the contraceptive plan is in place and ensure a clinical review is planned to discuss relevant issues regarding the future fertility and pregnancy, and complete the discharge summary and ensure that woman's GP is informed. In Australia, here is intra-sac methotrexate administration also. It is done under ultrasound guidance. Here we inject the methotrexate directly into the gestational sac, and here the surgical complications and risk of hemorrhages are very less, and it is a better option for a woman who want to preserve her fertility for the future. It is a first line treatment in cases of cesarean scar pregnancies and for cervical pregnancies. It can also used for interstitial or cornal pregnancies, but in cornal pregnancies the first line treatment is surgery. Both intramuscular and intra-sac administrations are off-label here. So the rate of success is more in intra-sac treatment than the systemic treatment. 93% success rate is there compared to 73% of systemic treatment. And it should be given in ultrasound department or in operation theatre, and the route of administration should be clearly specified to prevent inadvertent administration via incorrect route. The usual dose is 50 mg of methotrexate, and it should be administered directly into the pregnancy sac under ultrasound guidance by the specialist, either maternal fetal medicine specialist or any other skilled practitioners can give this. Methotrexate 50 mg per 0.5 ml pre-filled syringes are available in Australia in some sites for the intrasac administration. If fetal cardiac activity is detected, bolus of potassium chloride 5 to 10 millimole is injected directly into the sac. So some points about multi-dose regimen also. Like intrasac administration, here the multi-dose regimen also given for interstitial and non-tubal ectopic pregnancies management. And the treatment in these situations needs to be individualized with consultant gynecological and sonological input. And there is no authoritative therapeutic guidelines for a multi-dose regimen, but the following regimen may be suitable if the consultant decides the treatment should include a multi-dose regimen. So the regimen is administer methotrexate 1 milligram per kilogram intramuscularly on alternate days on day 1, 3, 5 and 7, maximum 4 doses according to the beta HCG level. Then administer leucovorin calcium or folinic acid 0.1 milligram per kilogram intramuscularly on alternate days, day 2, 4, 6 and 8, and continue the treatment until the beta HCG drops by more than 15% in 48 hours or maximum 4 doses of methotrexate. So what is leucovorin? It is an active metabolite of folic acid. It helps in rescuing the cells from the toxic effects of the methotrexate. So the monitoring is by beta HCG weekly monitoring and it should continue until the beta HCG become less than 5 international unit per liter or become negative. And after initial assessment, we should repeat the platelet count and liver function test on day 7 also. So that's it for the multi-dose regimen. So the last management, expectant management, it should be considered in cases of failing pregnancy or if we suspecting any tubal miscarriage, and if the woman is willing to attend follow-up when there is no pain or no tenderness attributed to the ectopic, and if the beta HCG level is low or falling or if it is below 1500 international unit, and if the ultrasound findings are inconclusive, especially the location of the pregnancy is inconclusive, we can give expectant management. So here the gynecology registrar will explain the management plan to the woman and partner and provide them written information including the emergency pregnancy assessment service and women emergency center contact details, and prescribe anti-D if a woman is RH negative according to the guidelines, and arrange a follow-up on day 4 and day 7. And day 1 is the day of diagnosis and treatment plan. Provide further contact numbers or appointments for women's social support services, and advise the woman regarding the separation pain and regarding the analgesia, and if the analgesics are ineffective, ask the patient to contact EPAS clinic or emergency center. Ask the patient to avoid vaginal intercourse to minimize the risk of rupture, and we should always thoroughly monitor the patient because we need to assess the change in symptoms and signs because there is always a risk of bleeding or rupture in case of expectant management. So when it comes to the follow-up and monitoring, it is almost similar to the medical management. Day 1 is a day of diagnosis or day of treatment plan. On day 4 and day 7, the clinical review is given by gynecology registrar with the beta HCG report. If there is any indication, we should discuss the case with the gynecology consultant. And on day 14, review the patient in EPAS clinic with the beta HCG. Here also, if any indications are there, we should refer the patient to the gynecology registrar. If the beta HCG fall more than or equal to 15% between day 4 and day 7, then we start the weekly follow-up in EPAS clinic until the beta HCG is less than 5 international unit, and it may take several weeks to fall. And if there is any indication, we can consider a review to the gynecology registrar. If beta HCG does not fall at each visit, discuss the case with the consultant gynecologist and consider whether the surgery or methotrexate is indicated. Similar to surgical and medical management on completion of treatment, here also we should ensure the contraceptive plan, we should ensure the clinical review plan, and complete the discharge summary, and ensure that patient's GP is informed. So this is a flowchart showing the medical management of ectopic pregnancy, and we should give the dose on day 1, and on day 4 and day 7 we need to review the patient, and depending upon the rise or fall in value we decide further treatment. So that's it for today. If you have any queries or suggestions, please add it in the comment section. And if you like the session, don't forget to like, share and subscribe. And thank you for watching.